السلام عليكم ورحمة الله وبركاته. مساء الخير، يومكم مبارك. معكم دكتور أيمن سمير. إن شاء الله حندير المودريشن لمحاضرة اليوم. هذه المحاضرة الثالثة من سلسلة محاضرات الانترفنشنال كارديولوجي. عنوان المحاضرة History of Interventional Cardiology. حيعطاها الصديق العزيز اللي نتشرف أن يكون معنا اليوم دكتور عبدالغني الساعدي. دكتور عبدالغني الساعدي Interventional Structural Cardiologist في تامبا فلوريدا. وعبد الغني من الناس المميزين اللي تشرفت بمعرفته من عدة سنوات في الجنرال كارديولوجي فيلوشيب، وكان واضح عليه متميز من اول سنه، والصراحه قدم الدكاتره الليبيين احسن تقديم، لدرجه نحن في المستشفى كانوا مسمينه بروفيسور السعدي. عبد الغني انسايكلوبيديا، انسان مثقف جدا، ولهذا السبب يعني احنا اخترناه انه هو يعطي المحاضره هذه الهيستوري اوف انترفنشنال كارديولوجي. حيكون معنا ان شاء الله نفس الشيء، يعني مجموعه مميزه جدا من الاكسبرت بانل، في دكتور عبد المنعم التومي من ليبيا، وفي طبعا استاذنا دكتور مهيار الحمداني من مارش يونيفرسيتي في يونايتد ستيت، وفي المميز دكتور عادل ديوب كارديك سيرجري من كندا. دكتور عبد الغني تقدر تفضل، وشكرا بارك الله فيك على تقبل الدعوه.
السلام عليكم ورحمة الله. فرصة سعيدة جدا نشاركوا في الميتينجز هذه، وصراحة يعني أيمن والجميع كل من مشاركين في الجمعية صراحة ما أقدرش أشكركم بما فيه الكفاية. موضوع الهيستوري اوف انترفنشنال كارديولوجي موضوع عزيز علي هلبة، وللأمانة يعني اللي خلاني ترسد في الموضوع هذا من البداية هو دكتور طاهر شفح في زمان في مستشفى شارع الزاوية. فكانت واحدة من السلايدز هني كان قصة هو حكاها لنا قبل، ف يعني it got me interested in cardiology in the first place، وهكذا يعني. فأنا feel يعني good homecoming feeling doing this topic صراحة يعني. بس نفتح الفيديو. Anyways, okay. So لو بشوفوا the history of interventional cardiology, you cannot really remove it from the history of cardiology itself. The history of cardiology يعني زي ما نعرفوه احنا they probably description بتاع الأنجنة اللي هي يعني في وقت الحاضر الكوروناري ارتري ديزيز هو المين بروبلم اللي احنا نتعامل معاها بشكل او باخر في كل يوم. فاول ديسكربشن الانجينا كان في 1772 بويليام هيبردن اللي هو انجلش فيزيشن. كان هو نفسه عنده انجينا، ف he was able to really describe it يعني زي ما نعرفوه احنا اليوم، يعني angina of effort to when you climb up it gets more, when you rest it relieves. فكان أول description الأنجينا. The reason اللي أنا ذكرت 1972 أن it took almost like 2 centuries for the next very important innovation or advance في diagnosis اللي هو في اعتقادي، واللي في اعتقادي ايضا له علاقه مباشره بالانترفنشنال كارديولوجي، اللي هو discovery of X-ray. يعني almost حوالي 150 years or so between the two. ف ويليام رانتجن زي ما تعرفوا physicist، ما هوش physician، ألماني. This is يعني the picture of his wife's hand. كانت أول X-ray اندارت في العالم. واحدة من الأسباب في اعتقادي أن ألمانيا لا تزال إلى يومنا هذا يعني المكان اللي نشأت فيه كل هذه الاكتشافات وكل هذه الانوفيشنز، وواحدة منها هي اكتشاف الإكس راي كان في ألمانيا طبعا. ف just to put everything in the frame of timing، 1895 first X-ray. EKG at that time was not even being considered. William Einthoven، لو تعرفوا من cardiac axis Einthoven triangle، هو اللي أول من developed EKG machine just to put everything in frame of mind 1910. ف still يعني حتى ذاك الوقت قاعد مازال ما فيش هذاك الدايجنوز، وما زالت حتى السبيشالتي cardiology as a specialty was not يعني well developed, well characterized. يعني عندك physician والphysician who does everything. في اعتقادي أنا بعد اكتشاف الاي كي جي وبعد ما الاي كي جي أصبح something that is done or needs gets more complicated وبدنا نعرف more and more about the EKG. That's when this specialty started to develop, the cardiology specialty. لو تتذكروا معي في الوينكي باك اللي هي progressive prolongation of the PR interval was described before the EKG was developed, was described from the jugular venous pressure. فيعني it took a while to get حتى to figure ان الوينكي باك phenomena is an electric phenomena يعني just in the frame of mind of everything, to put everything where it came بداية as we talk about the history of interventional cardiology. Up until 1910, discovery of EKG or development of EKG, I should say, the idea of putting stuff inside the body to get diagnosis or get some sort of therapy probably started with the Foley catheter. Frederick Foley, American urologist, actually developed the catheter not to relieve urinary obstruction, but to allow urinary reconstruction surgery. You know, they noticed in a lot of these surgeries, the ureter gets fibrotic. They came up with this idea. واحد من الناس اللي got really fascinated with this idea was Werner Frassmann. كان surgical intern في ألمانيا في 1929. كان يشتغل مع أدولف فيك اللي هو الشخص اللي developed the Fick principle. كانوا fascinated with measuring pressures و measuring oxygen levels. واحدة من البروبلمز اللي واجهت أدولف فيك إنه هو in order to calculate the cardiac output you have to have central venous oxygen saturation. How do we get that? They were like talking about it. Werner Frassmann was one of the interns. فشاف فكرة الفولي كاثر وكان في urology rotation. He liked the idea. بعدين شاف فيه someone did an experiment by inserting a tube inside the dog's heart. he proposed that idea to one of his superiors. وقال له يعني why don't we do this? So this will work. We get central oxygen saturation. We will get to give medications intravenously, the central circulation. And as you know, يعني ما كانش medications given peripherally was not effective, some of them. So his superior completely يعني asked him not to pursue this idea or prohibit you from doing this. What he did في December 1929 خلى everybody left the hospital. He asked one of the nurses to help him. He catheterized himself. He did a venous cut down on his cubital fossa, inserted a tube, and passed it as long as he can, blindly. And then had the nurse apply bandages on his arm, walked out of the room and went 3 stories to the X-ray department اللي هو كان في the first floor. Took this X-ray, showed this X-ray to his superior to say like, look, I passed it, it's doable. Of course, this didn't go very nicely. He was fired the next day. That was the end of that. 1929. After he was fired, he went ahead and published that one of the journals, a German journal. Soon after that, he joined and became a urologist. Then, في الحرب العالمية, he was enlisted in the army. He was sent to Russia, fought with the German army in Russia. بعدين he was أسر في روسيا was released بعد نهاية الحرب. رجع لألمانيا. Practicing as a urologist, doesn't know any. خلاص ما عادش, he didn't know where this situation went. After that, paper بتاعه was read by two American cardiologists في كولومبيا واحد في كولومبيا واحد في NYU. They actually were able to calculate the cardiac output. They started doing that in humans basically out of his paper. That was the beginning of heart catheterization. اعتقادي أن يعني catheterization, the word itself, probably has something to do with that. His fascination with catheters eventually led him to be a neurologist. Frostman, after this, he thought إنه he went into complete infamy. Nobody knows about him or nothing like that. But in 1956, he was awarded the Nobel Prize مع two American cardiologists اللي هم ديكنسون ريتشاردز أندري كوناند اللي هو اوريجينال فرنساوي بس كان عاش معظم حياته في امريكا وكان في NYU. that was the story that دكتور طه شفح كان هذا زمان في مستشفى شارع الزاويه. it was like يعني البدايه I was like يعني ممكن فيها شويه اضافات ولا شويه embezzlement story, but it was like truly exactly like he said it. That was such a fascinating story, which shows you like the kind of pushing the boundaries he happens. Yani he was told not to do that, he did it. Here we are. That was venous access. To do the same thing in arteries was a little bit of a difficult problem. And how do you access arteries, which are pulsatile, which are smaller, which are more muscular? How do you do that? This is still, we're talking in the 1940s, بداية the 1950s, when the brachial artery cut down became the predominant way of access. And to do that, basically, you have to put a burst string before and يعني قبل proximal or distal to the intended site of access. You have to cut the skin, and then you have to insert. You have to really like with a scalpel make an incision inside the artery, and then insert the catheter, and then you tighten the burst strings until you finish with your procedures. Yeah, so that was something. You could bleed. It's invasive, as you can see, but this was the predominant way of access for a while. For at least 25 or 30 years. يعني ممكن من أواصل الأربعينات إلى حد أواصل الستينات, there were still people who were doing it only this way, including يا أيمن, if you know Dr. محي الدين, كان عندنا دكتور قديم هلبة في Creighton. This is the way he was doing it. I had one patient who was telling me once, he's like, oh, I had heart catheterization. I was like, to your arm or to your wrist? I go through my arm. I was like, I'm explaining to him about radial access. He's like, no, last time when I did it, they did it when he was a kid, they did it in my cubital fossa. We were going through his cubital fossa. That was the predominant way of access, basically, for a while. Until our friend Sildinger, who was a Swedish radiologist. And again, يعني بوريكني بس إن this specialty came out of other specialties. All the specialties, at the end of the day, you're just treating the same disease. You're collaborating, adding different skill sets. For Sildinger, method of access is what we know right now. We take it for granted sometimes. And yeah, you access the artery, use needle. But remember, for at least 25 years, nobody could figure this out. This is the original Sildinger technique, where you puncture the artery through and through. What we use now is the modified Sildinger technique, where we puncture the anterior wall of the artery. And if you look at step number 5, that's like also something, you puncture, you back the needle, and then you press to hold the wire, just so that you do the exchange. And the wires initially were not very easy to advance out of it. That's the Sildinger technique. This became the main access methodology for the rest of our job work. It's kind of, right now we use these sheets, like that's the Edwards TAVR sheet, which is like a marvel of technology that can expand inside the body. allow a valve. It's nice to realize how this was done differently, very differently before than we know right now. The act of revascularizing to improve angina also was not a simple thing that came to mind. A lot of cardiologists and a lot of scientists did not believe that it is useful or something that should be done to revascularize the artery. Actually, a lot of them did not believe that a blockage in the artery is responsible for angina. There's a lot of debate. So there was initially a lot of experimental surgery, and Alex Carroll is one of the first ones. I think there were others who were trying differently, but he was one of the first ones at Johns Hopkins who tried to make a connection between the aorta, or do some sort of what we know now as cardiac bypass. Very difficult technically, very bad results, could not survive. The next person who was very famous for doing this is Canadian surgeon Weinberg, who basically used Carroll's experiments, used other people's experiments, and tried to say, why don't we take the internal mammary artery and just implant it in the muscle of the heart to allow it to perfuse the heart. And at this time, in 1945, the current technique of anastomosing arteries and tubes and the small these small 0.8 or 0.9 sutures or whatever, they're not available. His surgery was literally just taking the internal mammary and making an incision inside the heart muscle, and then just implanting the mammary inside of it, and basically hoping that the mammary will develop collaterals and connect to sinusoids inside the heart muscle. Again, the one person who told me about this, Dr. Easterbrooks, and I'm like, okay, can you think, how can you implant that inside an infarcted muscle that's might be ischemic? As you can imagine, the original results were not very successful, but somehow Weinberg was one of the ones who succeeded in getting a foothold. But again, was faced with huge criticism, and the mortality rate was 70%. But he has few people who lived with this and had their angina relieved. But he could not prove that this strategy of revascularization works. Still had lots and lots of criticism. He actually did one of the very original case control studies. Everybody, when you talk about case control studies, everybody tells you about Dahl and Hill experiments in Britain. But Weinberg was one of the first people who actually did a control study, and unfortunately didn't see the day of light until later. It was not lima to LAD, but it was lima to myocardium, so to speak. This was one of the very first daring experiments in Quebec. It was in Canada. A lot of the heart catheterization, the early heart catheterization was heart catheterization in the sense that it was used extensively, diagnose and prove or disprove congenital heart defects, prove or disprove presence of heart failure by measuring pressure, by obtaining oxygen, by calculating cardiac output, this kind of stuff. And one of the very early people who dabbled in the heart catheterization was Brownwald and Brockenborough. And one of the very funny stories that I heard once in a conference Dr. Brownwald mentioned is the discovery of hypertrophic cardiomyopathy. So he used to work at the NIH in Bethesda, Maryland. And they get to catheterize patients that were thought to have aortic stenosis. And at that time, in the early 60s, diagnosis of aortic stenosis goes like this. You have a murmur, you go and get heart catheterization, measure pressure in and outside across the valve, and that's how you get diagnosed with aortic stenosis. At that time, know that a variety where there is a subaortic stenosis. So Dr. Brownwald cath patient who sent him for surgery for aortic stenosis. The surgeon with him اللي هو مورو اللي mentioned his name في الsign هذه. Dr. Morrow opened up the patient, opened up his aortic valve, looks at his aortic valve. His aortic valve is completely normal. So calls Dr. Brownwald to the OR. Jean Brownwald, you got the numbers wrong. Look, so he made him put a glove on his finger and made him put his finger through the guy's aortic valve intraoperatively, just to tell him that this guy does not have aortic stenosis, and your technique and your numbers suck. So Brownwald, he could not figure this out for a few months until he got the idea that maybe, with the patient being in the OR with cardioplegia, with the heart being in arrest, maybe there is something dynamic. So he brought the patient back, cath him again, and found out that he actually still has this gradient. Only then they figured out that, there's a difference between this guy's gradient, in which the pulse pressure increases after a PVC, and other people's aortic stenosis, which the pulse pressure does not change or decreases after PVC. So from that came this Brockenborough-Brownwald Morrow sign. Funny story that just kind of tells you the early days. There was a lot of pushback against all of these, but just the persistence of these people like Dr. Brownwald just kind of proved to everybody that there is an alternate explanation. It's not that the technique is wrong. It's just the disease is variable. That was that. One of the very early people who was ahead of his time in heart catheterization was Mason Sones at the Cleveland Clinic. Dr. Sones, very famous. He does all his procedures through the antecubital fossa cut down and has this catheter that you see here. This it looks almost like a multi-purpose catheter. But again, he was only doing, everybody at this time never look at the coronaries or anything like that. You just measure pressures and obtain oxygen, calculate output. That is heart catheterization at that. One of the times, again, this is just like, shows you like a sheer luck. Dr. Sones doing a procedure, his assistant is injecting on the manifold. He goes to take the X-ray. At that time, the X-ray is just a still X-ray. I mean, you situate everything. You put your catheter where you think there is aorta or there is something, and then you go and activate the X-ray, and then you obtain the image. With the image, usually is a still image like that. It's not a what we obtain right now. What we look at right now.
عبدالغني عفوا، يا ريت تقرب من المايك لأن مرات صوتك يبعد شوية.
Okay. Let me see. يعني والله راه قريب على المايك عند لاصق في الشاشة.
كويس، تو كويس، ممتاز.
Okay. All right. For Dr. Sones, his assistant, they put the catheter in the aorta. They're trying to do an aorogram. Goes to activate the X-ray to take picture. His assistant started of contrast. With contrast in those days was very thick contrast, and it's not like what we have right now. He goes to activate the X-ray to look if it's good or not, and his assistant starts injecting. Find out that they're injecting inside an artery, which happens to be the RCA in this case. He panics and he looks at the monitor. The patient goes into bradycardia, then cardiac arrest, or like a long pause from the dye injection. In the contrast, very thick, it stayed within the blood vessel. He jumps over the patient's chest, takes a knife. He was going to open the guy's chest to do internal massage. Seriously, that's what he did. While he's on top of the guy's chest, he asks him to cough, and the guy coughs. As he coughs, he gets his pulse back. So he was scared, and this guy is like sitting on top of his chest with a knife. And he's like, "What are you trying to do exactly?" Kind of a funny story. But that was the first time that anybody did a selective coronary angiogram. Well, he got it also on X-ray. Okay, getting back to the X-ray team. And that was the proof. At that time, 1958, Dr. Soames, he said that I realized that this is a technology that's ahead of its time. Remember, Weinberg could not prove to anybody that his grafts are working. Everybody was like, who knows if the grafts are working or not? So this was the way that it started. Soon after this, Soames started doing this routinely. He's like, if we can do it with this large amount, with 30 cc's of dye, if we could do it with a smaller amount of dye, probably be safe. And it was. No IRB approvals, no submission to FDA, nothing like that. So that's the way it was. By time everybody else started doing heart catheterization, like in the mid-60s, the Cleveland Clinic at that time had done thousands of these cases. That's what gave Cleveland an edge over everybody else. The other thing that Cleveland had that was ahead of its time is their experimental use of the Weinberg procedure. So they used the Weinberg procedure extensively, and one of their surgeons was very, very famous. You probably knows him very well. Rene Favellaro was an Argentinian surgeon. He was the first one who sort of developed or used the vein graft. It came in use because one of the Weinberg patients they had to do a vein plasty to one of the Lima grafts, and it was short or dissected or something like that. But they're like, if we could sew the vein into the artery, then why don't we just take the whole vein and put it in the aorta, put it in the artery? He did it, and it was a huge success. Favellaro's success, as opposed to Weinberg's lack of success, was predominantly because of his collaboration with Soames. He was able to prove to everybody that, look, so the vein grafts, here's the before and after images. That was the beginning of selective heart catheterization. And soon after that, the technique is being developed differently. Soames catheter, this is Soames' first picture is Soames, and that's his catheter, had an end hole, which is at the tip, and a side hole, which is kind of funny because when the Japanese developed the radial catheters, they all developed side holes also. So again, when you're coming from the arm, you might not be engaged selectively or selectively enough. So that side holes is very key. The technique that is used predominantly now is the Shotkins technique. And Dr. Shotkins, again, interventional radiologist, not a cardiologist, at the University of Oregon, developed this curved catheter and was one of the first ones who used the Sildinger approach from the groin. So that was something that they did extensively at the University of Oregon, and they were doing a lot of visceral angiography, lower extremity angiography. So they were accessing the femoral artery a lot. So they used the femoral artery to access, and Judkin's curve still used till today. And in his words, if you push this catheter blindly, it will find its way. And it's for the most part, anybody who does heart cath knows that that's true. The other strong, big technique and catheter that's still available until now is Dr. Umplaut's catheter. Dr. Kurt Umplaut's was at the University of Minnesota, Namsawi. Again, a lot of IMGs. Not a lot of people, not Americans or anything. It's just like multiple nationalities collaborating and converging on this. But Dr. Umplaut's catheter is a catheter that needs a special way to engage. It can be a very lethal weapon, though in the entire you don't know how to handle it. And it has to be face to the artery and then pushed against the cusp. And when you push it against the cusp, the tip of the catheter engages the coronary. Some people you call that unplatting even, and they still use it as a verb even for his name. His name is also, you can find his name a lot with a lot of other closure devices, like the Amplatzer devices for septal occlusion, ASD occlusion, PFO occlusion. That's all his ideas and his work. The biggest move from being a diagnostic procedure to being an interventional procedure came from, again, the University of Oregon. And Charles' daughter is an interventional radiologist who used to be the Judkins boss, so to speak. So they used to work together. And daughter's main thing was doing lower extremity angiograms, peripheral vascular disease. He was the first one to do any interventional procedure. And he believed that, in these patients who are destined for amputation, there's got to be something else can be done. If we swear that this is secondary to vascular occlusion, why don't we just fix it? And he used to do a lot of angiograms for the surgeons to prove that the vessels are occluded, stuff like that. And then one day he developed these tools, which are like graduated catheters. So it's like a catheter that is gradually taper, and he would insert it into the lesion, like you see here on the bottom left, and slowly dilate it. And to this day, all of us who put stuff inside vessels, you say the word daughtering, or daughter, or daughter the balloon, or daughter this, or daughter the microcatheter. So what that means is basically this: inserting the thing and pushing it slowly to enlarge the lumen. And the name, the verb came from his name. So when your name becomes a verb, you are very established. The funny thing also about Dr. Daughter, historically speaking, is that if you look at this excerpt, this is the one, the top right slide. This is a request, a consultation request. For the surgeon, look what the surgeon wrote: visualize, but don't try to fix. Now he knows, and he's really a little crazy. He can do stuff. But very very creative mind, pushed the boundaries. He allowed this field to push further. There was, so for 1962, there was a lady, this lady, Laura Shaw, University of Oregon, 82-year-old lady. She had gangrene, or she had cold limb from knee down. They told her, like, you need an amputation. She said, nobody's amputating my leg. He saw her, and he basically ordered her distal SFA. Dr. Mahiari tell you that portion of the distal SFA at the adductor canal, still to this day, is the same segment that always gets occluded. That's the most notorious area of the SFA that usually gets a lot of disease, right? So he basically opened that, and she healed her gangrene, and she did not get an amputation. And she walked out on her feet, 82 years old. And that was the first pretty much angioplasty, or the first interventional procedure. Of course, he was called all sorts of names. He was called a criminal. He was told that he was in jail. Some people accused him of malpractice. But this is where we are now, right now. And after a while, this became more established. He's a little crazy daughter, and ended up being on Life magazine, featured on Life magazine for this procedure. Meanwhile, back in Cleveland, this is Rene Favellaro, the guy who sort of developed the vein graft, or done the first saphenous vein graft surgery, and only after Mason Sones was able to catheterize and prove to everybody that Weinberg procedure works, which is these angiograms here on the side, that everybody started thinking about cabbage as being a viable option. And there is an excerpt from I just couldn't get it. It's a video from Favelaru attesting that, saying like if it wasn't for Mason Sones, there would be no cabbage. It just kind of shows you that all these things go hand in hand. It's not a competition or any of that. One of the people who were very influential, probably the most influential in interventional cardiology history, is this guy, Andreas Gronzig. Andreas, again, a radiologist, born in East Germany, across the border from East Germany to West Germany with his mom, single mom, lived in and studied and read and went to mid school in Germany, then went to Switzerland to work. He went to one of the radiology conferences and saw cases presented by Charlie Daughter. And he was fascinated. And he was someone who used to do a lot of coronary angiograms in Switzerland. He kind of was thinking, why don't we use the same technique in the coronaries? Again, at that time, there was no devices. Nobody believed this, yada. This is on the side here. This is his kitchen table. And him trying to make or develop a balloon cath that could fit inside the coronary. Like when you talk about the femoral artery, it's a 6 millimeter, 7 millimeter vessel. The coronary is a 3 millimeter vessel, 3.5 millimeter vessel. So you need kind of a lot of engineering for that. And he took it upon himself, and then he made these balloons, and he used to sell them himself out of his house. So again, a lot of criticism in the beginning, a lot of pushback in Switzerland, in Germany. Nobody believed, nobody does. So what Andreas did is he really did it in a very phenomenal way. He literally would measure pressure in the coronary, and this is like way before the time where there was fractional flow reserve, FFR, IFR, this kind of stuff. This is before there was any coronary guide wires. So he would measure pressure through his balloon. So he would take the balloon, cross the lesion, measure pressure distal, and measure pressure proximal, dilate, and then would show everybody the improvement in pressure. So he did his work initially in animals. Then the next trial area, usually for most interventional procedures, is the peripheral interventions. So he did his balloon.
Abdulghani, الصوت هرب.
أيوة. And then he tested his work in femoral arteries. Then eventually, ultimately, when he presented, so this poster was the American Heart Association meeting, Miami in 1976. This was in dogs, in the heart of, in the canine heart, the dog heart. Some American cardiologists got interested. They visited him in Germany, in Switzerland, in Zurich. They wanted to bring the procedure here. Somehow he managed to do his first case in Zurich, which is September 16, 1977. And this patient's name is very famous. His name is Adolf Bachman. And proximal LAD, like you see there. So the balloon gone, nice result. Don't see these patients anymore. But so this was, his balloon in the beginning was pretty big. So you cannot do a tortuous vessel. You cannot do beyond maybe prox LAD, prox circ, prox RCA. Then slowly, the technology got much better and improved. Granted, if you want to go over his story and lifetime and his contributions, it will take a full lecture. I am not giving him his credit by just giving one slide, but he was like really instrumental in so many ways. After that, he left Switzerland. He came to the United States, to Emory University. and unfortunately died in 1985 in a plane crash. That same year, he died. It's funny, but that's kind of, you could look it up. Mason Sones, Charlie Daughter, Shotkins, and Grunzig all died in the same year, 1985. It's kind of an odd thing. But angioplasty caught up, immediate success. Again, there was a huge criticism, a huge pushback. At this time, like the early 70s, CABG was being established as a successful procedure and was being done significantly. It was seen that this is like something that's going to take CABG away and yada yada. The first few procedures, Emory, before Grunzig arrived, were done on patients who were like they would do one vessel CABG and they would do it intraoperatively. But ultimately, this became an established technique. In the beginning, the catheters were big, 9 French catheters. Everybody was bleeding in the groin, or a lot of complications. Slowly, the technique is tweaked, and now it's where we know it. At some point, the biggest problem with plain old balloon angioplasty is acute closure, which used to happen about 30% of cases. So you take some patients, balloon them, and a minute start having chest pain. You take them back to the lab. The vessel is closed shut. To solve that problem, another international graduate, Olio Palmas, Argentinian cardiologist, he was like, why don't we just put a stent, something that comes crimped on a balloon that could be expanded and would keep the vessel open. And here we go. And this was the birth of the bare metal stent. This came about like mid to maybe early 90s, I think. And the bare metal stents, their main problem is this, which is neointimal hyperplasia. And slowly but surely, again, lots of criticism, lots of this, lots of that. And slowly but surely, drug-eluting stents came to the picture. And the first Cypher, drug-eluting stent approved in the United States in 2003, became sort of the established method of treatment. A lot of other stories and everything, but I kind of knew if I can talk, and I can tell you I could talk forever. So I'm gonna keep it like short so that we have some discussion and some back and forth. There you are, and thank you so much, everybody.
غني بارك الله فيك. يعني الصراحة أنا استمتعت بشكل مش عادي. السرد الأحداث كيف حطيتها بطريقة ممتازة جدا. أظني في clear message من البرزنتيشن متاعك إن الفيلد to evolve so much. يعني too many people has to contribute, teamwork. It's no one man show. فتكلمت على إن physician, cardiologist, radiologist, scientists from Germany, from Swedish, French, the United States, أرجنتينا. تو اللي حضروا اليوم محاضرتك يعرفوا مش مارادونا وميسي بس، يعرفوا وبامز البيرميتال ستنت. فأحسنت صراحة، استمتعت جدا جدا. مرة صوتك يهرب، لكن يقولك الحلو ما يكملش. والله بجديات أكثر محاضرة استمتعت نسمعها. طبعا بالنسبة الاتندنس، يا ريت لو حد عنده سؤال يكتبه في الشات بوكس او ريز هاند نعطيك المايك. طبعا تو حنفتح المايك للاكسبرت بانل، دكتور مهيار، دكتور عبد المنعم، ودكتور عادل. لو كل واحد فيكم يعطينا هيك فيو مينت البرسبكتيف بتاعها على الموضوع هذا. تفضلوا دكتور مهيار، تقدر تبدا. دير انميوت.
اي ان شاء الله. اهلا وسهلا. لا بصراحه بالحق يعني انا مش عارف شو بنقول. يعني it's a very very nice presentation. I mean it's a very difficult topic. The topic is boring by itself, history. I mean I don't know what it is, but You made it so good. I mean, let me tell you, I mean, it's really fantastic. I'm going to talk about a few things. I don't want to forget Ibn Nafis. So Ibn Nafis is the first person who described the Dawra Damawiyya, who really told us that there's a right heart, and the right heart pushes blood to the lungs. The lungs brings the blood to the left heart pushes through the aorta to the body. Just want to give a credit to one of the pioneers of medicine, who is Ibn Nafis. The other thing that I want to talk, you're absolutely correct. Pushback. This is even today in your own practice, any one of us, Abdulghani or anybody else, whether it's imaging or any form of practice, when you start something new or even something is known, but you want to adopt it in your institution, you're going to have a pushback. You start with, this is impossible to happen. So it's like unreal. Then you become to reality, but it's not needed. I can do without this. Then the next stage, it's now so commonly used. The same people, they will tell you, well, it's okay. It's an old story. So this is really true. Anything you start, anything started in the past goes through these three stages of comments that we face every time we do anything. The other thing that I would like to talk, which is I just, witnessed in your speech that you used the word left heart catheterization at the time of Brownfield and before Brownfield, etc., which is until today, the word left heart catheterization, it doesn't mean selective coronary angiography. It means really the catheter inside the left ventricle. Even in coding, when you code for left heart cath, meaning that the catheter passed the aortic valve to the left ventricle. Doesn't mean that you did a coronary angiography. So your coding is left heart catheterization, left ventriculogram, selective coronary angiography, and just goes in. Why we call it this way today? Because of that history, because somebody made a left heart catheterization one day, then they added a left ventriculogram, then they added selective coronary angiography, and each one of them, when there was money in medicine, each one of them has a code, has a money to it, and so forth. The other thing that I'm gonna add, it's very interesting because angioplasty and stenting, when it first adopted, even the coding of angioplasty and stenting was like doing a cabbage. There wasn't a code for them. Like people that I didn't witness that, but but my senior, who's still my partner right now, he doesn't code for angioplasty or for stent placement. He codes for a bypass surgery, and that's why even then, the reimbursement for angioplasty and stenting was enormous. Was just enormous, like doing a bypass surgery at that time, which I thought this would be very interesting. I witnessed as an observer where they put the Palma stent on the balloon to deliver it. And that was a very scary moment. And I've seen in front of my eyes where it's slipped and lost. This still happens rarely right now, but more commonly during my training and practice as an interventional cardiologist with the old generation stents. But that was really very common then with the Palma stent, and I think that's worth to mention. I used a lot of Cypher stent. One of the best stents that I can really attest that that until today that I like, and sometimes in some cases I wish I still have it to put it, just because it's hard to deliver, et cetera, but they really last long enough, especially in certain cases. Of course, now we are at the 4th generation of stenting. And I still remember when I first started using the driver stent, and now we are at the Resolute stent, and this is the 4th generation, if you just talk of one company. But there's so many companies, as everybody knows, and so many stents that we had. It's just one thing that I felt would be nice to mention, that there used to be an atherectomy device for the intracoronary. So and this is something that I've seen, I never used, but I've seen when I was attending in medicine at that time, that the patients will go down to the cath lab and they will do an atherectomy device, and of course,
Directional, you mean directional atherectomy?
Directional atherectomy, yes. So they will do directional atherectomy, and that's not valid anymore. I mean, there was so much complications at that time, but that was before the stent is out. Either you do angioplasty alone, or you do directional atherectomy, or you do rotablation standalone at that time. And rotablation is really still a valid option until today as a standalone. If you have a case that you don't want to really mess up a lot, just use a 1.25 and just do so many runs with that, and then maybe go another 1.5 and just stop there. There's no dissection, there's nothing, but you really created a little bit of an improvement if you don't want to stent that artery because it's a mid to distal LED that is a small or whatever. So I think, you know, and I've done that.
دكتور مهيار سامحني خلينا في الهيستوري مش تكنيكال وعلى الفيلد انت
No. I mean, I'm talking historical. Because these are as Abdulghani said, there's so many others that it will take my whole day. That's why I mentioned the directional atherectomy, because this is historical. It's not even available anymore.
Shockwave lithotripsy now. Shockwave lithotripsy.
Shockwave is a new true. These are advancements though. So but yeah. But I mean, great, Abdulghani. I mean, really enjoyed it. It's fantastic. And I'll leave room for the others. Thank you.
دكتور مهيار لحظة قبل ما نمشي للدكتور عبد المنعم وعادل والاودينس في تعليق بسيط من الشات بوكس على الكودينج. الكودينج زي ما عارفين في الهيلث كير سيستم في نورث امريكا يعني if you do procedure there's a billing code for it يعني every procedure has a price معين فلما الكودينج يعني you pay for it فلما you do more thing. لكن دكتور مهيار بنكلمك عليه تو بالذات بالنسبه ليك انت يعني من الناس السينيور الايفولفنج بتاع الفيلد. هل تعتقد ان تو في at this time there's a place to use bare metal stent at this stage of يعني ها انت حكيت على الفور جنريشن drug eluting stent لان انت زي ما عارف لما البير ميتال ستنت يعني ديفولف وبعدين الدراج ليوتين كيم ان it was the main advantage for bare metal stent اللي هو الستنت ترومبوسيس shorter duration of antiplated بس كان في المشكله بتاع ستنت انستينوزا. فيتعلقنا على النقطه هذه وهل في رول المين كويشن هل في رول توا في or do you use bare metal stent in your practice anymore؟ وعبد الغني
I don't use them anymore. There's no really in my practice, I mean, I'm not gonna really talk about everybody. I haven't used bare metal stents for the last 3 years. And I'm more and more now with the fourth generation out this past year. Absolutely, I will never use a bare metal stent. There's no point of using bare metal stent at all. You know, the last study about Resolute was about 1 month of antiplatelet therapy. Yeah. So, I mean, I don't think that there's really any. But you know, this is in my practice. So.
بالضبط. لا I think it's in our practice too. عشان لأنه الدراج ليد ستاندر gets so good وزي ما قلت الريسك اوف ترومبوسيس لو. عبد الغني عندك تعليق على النقطة هذه قبل ما نمشي لعبد المنعم والدكتور عادل؟
نفس الشيء حتى ممكن I think in the last 400 PCIs maybe مرة واحدة just because it was the left main we could not have a stent size to that except an old bare metal stent. But yeah, never use it. Will like Dr. Mahir said, new Resolute stent 30 days, new Sky Point, the new Zion stent, Abbott stent 28 days. That.
طيب ممتاز. عبد المنعم يا ريت تعطينا كومنت باش بعدين ناخذ الكارديك سيرجري برسبكتيف من عادل لان راه بقول لكم حاجه اللي يسمعوا فينا عادل زي عبد الغني حتى هو انسايكلوبيديا وفي الهيستوري ما نحكي لكمش.
الله يبارك. حقيقة محاضرة قيمة جدا حقيقة استمتعت بها واستفدت منها. برغم ان الحاجات اللي في بالي مش كثير انا اعرف اني اول واحد يعني دار الانجيوجرام 1977 البير ميتال ستنز لكن حاجات ثانية حقيقة جديدة علي ربما ما كنتش نقرا في التاريخ هذا. وحقيقة this field is evolving too quick and at least I can say in the last 10 years while I was in the UK يعني حقيقة يعني أنا لحقت على البير metal stent. Maybe the last bare metal stent was used in my center was in 2013 and since then I mean with the introduction of the new generation stent and the short adapt and I think in the introduction of the biofreedom stent, I think there's no need now anymore to use the bare metal stent. Some doctors think it's a crime putting now a bare metal stent because the risk of instant stenosis is quite high. Interventional cardiology is evolving too much and actually especially in the last 5-6 years. نتذكر أول ما بدينا نشتغلوا يعني كنا نشتغلوا على يعني السمبل angioplasty was just wire balloon stent. بعدين دخلت عليها، يعني ما بيش نتكلم على الاولد هيستوري but at least short in 2-3 minutes كيف يعني تطورت الانترفنشن كارديولوجي من الانترفاسكولار ايميجينج، اصبح في الايفس، اصبح في الاوبتيكال فريكونسي دومين ايميجينج او دي او اف دي اي، اصبح في الاو سي تي، اصبحنا في برنامج unnecessary stenting by using the FFR, the hyperemic pressure ratio, or the non-hyperemic pressure ratio, like the FFR, or even the resting full cycle ratio, or the RFR. بعدين اصبحنا طبعا في السي تي او طبعا تقدم كثير جدا، واصبحنا في برنامج نيو وايرز وجايا وايرز ومايكرو كاثيترز ومش عارف شنو فاين كروس وتيرن بايك ال بي وكورسير برو ودبل يومن كاثيترز توين باس وسوبر كروس. حقيقه يعني الانترفنشن كارديولوجي is advancing too much and too quick. ايضا حتى في الستنت يعني عارفين ان حكايه الستوري ان اول ما طلعت طبعا البي في اس والبايو ريزوربل فاسكولار سكافولدنج، بعدين اختفت من السوق. طبعا عارفين ان دي ستنت have got thick struts ولقوا ان الريسك اوف instant thrombosis quite high. now they're not using it anymore. والديديكيتد ستنت زي الترايون والاكسس ستنت، هذه كل ستنت طبعا طلعت وبعدين اختفت شويه لان يقول فيها الريسك بتاع الانستنت ترومبوز and instant restenosis quite high. حقيقه يعني التطور رهيب جدا يعني في الانترفنشن كارديولوجي over the last 7-8 years.
شكرا دكتور عبد المنعم، يعني very nice comment. وبالذات تكلمت عرجت يعني على الريسنت ادفانس in your time. وفي نقطة مهمة لأندرياس جرينسج عبد الغني تكلمت عليها، البايونير في الانترفنشنال كارديولوجي في اليونايتد ستيت، والدكتور ما هي يعرفها، كانوا يجوا في كورسات. طبعا هم إيموري يونيفرسيتي they were able to recruit them، جابوا اليونايتد ستيت على اساس انه يعطونا لاب وتو ايفولف الفيلد، لانه هو هي ستراجل يعني with that. انت وريت البوستر بتاعه اللي في ميامي بتاع الامريكان كولج اوف كارديولوجي. فانيوي they used to يعني الجاد فاذرز بتاع الانترفنشنال كارديولوجي ستيت they used to go take courses with him for a week or two. they have like a group picture of 150. هو كان الباشن بتاعه فلاينج يعني كوميرشال فلاينج، فطارت يعني he died in accident في طيارته يعني الخاصه. زي ما قلت عدول تعلقنا على البرسبكتيف بتاعك على المحاضره وتتكلم على السيرجري والرول. انت لما درت كارديك سيرجري بالنسبه هذا ريني فافيليرو، عارفين هو الارجنتينيان ميسي بتاع الجراحين الارجنتينيين في الفيرست كابج. تعلقنا وتفضل.
السلام عليكم. Abdulghani, well, a superb presentation. I have to admit it was very quite entertaining to see the sequence and the flow of the events. طبعا cardiac surgery, I don't think you're going to be expecting to sympathize too much. Just the introduction, because you're going to expect some hard time comments from our side. And I think one of the take-home message from this presentation shows and highlight the importance of teamwork. I myself experienced it since I joined the Mitra Club and the TAVI team. The amount of skills I acquired and transferred them to my own field when I started doing the mini AVRs والميني كابج والفيمورال اكسس وما عادش فيه كت داون وكله يعني بير كلوز وكذا. ف you mentioned it مرة سلتنجر، واحد سويدي، واحد راديولوجيست، واحد. ف I think that's how things evolve. We also have to admit that these guys they have ideas, they have technology next to them, they have good industry, they have good engineers. So any idea they have, they can translate it into action and into tools. يعني في ليبيا انت في 1920 او في 1910 ان شاء الله عندك 1000 فكره. كان لحقت على عشاك حالك باهي، كان لحقش تاكل هذاك اليوم امورك 100%. فاحنا we should not be taking this. Unfortunately نحن في العالم تاعنا ما عندناش how to translate this knowledge and this idea into action. فزي ما you mentioned ألمانيا وكذا، فكانوا ما يخافوش حتى من ناحيه ان يديروا حاجه ويغلط ويموت المريض الاول والثاني والثالث. يعني حتى في history of cabbage، يعني لما داروا اول كابج ما did not report until a few years later. حتى تتكلموا عليه احنا ممكن اليوم الموضوع هذا specifically was mostly toward coronaries، لكن هو احنا لما intervention world is a big field. يعني ما تكلمناش على الروماتيك، على البالون فالفوبلاستي، ما تكلمناش عليه الكوميشيراتومي، ما تكلمناش عليه كيف كان يديروا في يعني في المثال اللي انت mentioned تقريبا، يعني عندي محاضره شبيهه لها الهيستوري بتاع كابج. الدايجنوس هذا ميسون سونج في امريكا. I think he injected the RCA accidentally. It was not his mention. He was working up somebody for rheumatic heart disease and he found there's a contrast. So it was
هو كان يدير في ايورتوجرام و by mistake.
By mistake he diagnosed that there's an RCA. Exactly. Yeah. فبالنسبة لي فافالورو أنا I was lucky or not lucky, but when I joined the program in 2001, the chief of our department was one of the trainee of fellow of Favaloro in Cleveland. حتى عندنا الفافالورو retractor for memory وكذا. ففافالورو يعتبر هو probably one of the godfather, the one that popularized the use of the memories in the late 60s and 70s. By 2000, I think by 1986, the Cleveland Clinic published the paper that if anybody of you knows that Lima dominance in the cardiology or cardiac surgery field is coming from randomized controlled trials, that is not correct. That is only a observational paper that came from Cleveland, that published 10 years patency of Lima and the freedom from I think the outcome mortality. It shows that Lima is superior, and that paper stayed from 1986 as the gold reference. Like every paper, every presentation, they will refer to that paper from Cleveland Clinic. The thing that I would probably, as a cardiac surgeon, it always fascinate me from the cardiology side. Cardiac surgeons are lazy. They're busy, they work, they save life. They don't put their acts together, they don't publish, they don't evolve the field. The cabbage is the same. يعني cabbage 40 سنة ستونوتومي ليما veins ممكن شوية ريما شوية راديال وبرا. جماعة الكارديولوجي شد عندك غير اسماء ستنت واطلع وخش ونوع الوايرس لين تدوخ. But they are very smart in the way they every time they do something they publish, they show. So you can actually track down. يعني عندي very nice slide that shows الإيرا تبع percutaneous transluminal plasty، بعدين خشت الميديكال ثيرابي، بعدين خشت معها الستنت البير ميتال، بعدين خشينا في الدراج جلوتين، وهلما جرة خشينا في biodegradable ومش عارف ايش. ف it's the most elusive topic that you cannot have hands on.
باهي عادل. خلاص كمل في last minute وبعدين قول لي.
I just wanna يعني في الآخر I think it's important to in this time and age I think we have to زي ما قال Abdulghani, I don't think it's a competition. I think it's we're going back to the 50s and 60s. I think there's an era in my practice or my training where cardiac surgeon like أعداء. توا ولا من جديد في التافي والميترا كليب والترايكاسبيد كليب والهارت تيم ولا المانديشن even يعني mandate and guidelines وكذا. I think it's always going to be that cardiac surgeon and cardiology work together. Whether you like or not the stents, no randomized controlled trial will beat the Lima and the long-term patency of Lima that has been shown in all the randomized controlled trials, Syntax, Nobel, Excel, you name it. But good luck, and I think time will.
احنا الوقت ما عندناش. قلت لك انا ما يعني a statement I always use. I say the Lima the best stent we ever have.
بس على فافالورو يا عادل. انا قلت لك يعني لو نقدر كل سلايد من السلايدز ما محاضره في حد ذاته. لكن زي ما قال مهيار، انا اول ما التوبك بتاع الهيستوري دي قلت والله حتى ما قلت نخدم يا عمري مش توبك يعني بتخليها انتراكتيف وممتعه يعني صعب برا. فانيويز حاولت اخليها من فوق لفوق. لكن حاجه على فافالارو كان لو تقرا his biography very interesting. الرجل هو كان family physician بدايته في الارجنتين. He was a family physician. بعدين سيب family medicine. He was like a country doctor, like he goes in the country and does stuff. بعدين سيب family medicine.
غني حتى انت واضح عليك family physician family guy. ربي يحفظه جاد.
الله يسلمك. باي فسيب family medicine خش psychiatry في الارجنتين. بعدين somehow he meandered هيك قعد يحوم هيك ومشي يمين ويسار. somehow ended up in the Cleveland Clinic, trained as a surgeon ومشي في السياق هذا. It's very interesting. يعني الناس هم منهم بداياتهم يعني مثلا دارر هدايا وجوتكنز at their time في ال 50s the word radiologist does not exist. They are physicians that they do a lot of work in the angio suite. بعدين هيك they became sort of radiologists. حتى ال evolving of these specialties كيف الناس
بس
شيء يعني
في حاجه عبد الغني I have to mention it. انت قلت كلمه من بدري very interesting. No FDA approval, no REB submission, no whatever. قبل في الخمسينات والاربعينات غير انت عندك فكره تطبق مات عاش غير امشي قاعده تو بعض الدول الاوروبيه وفي مصر وفي الدول العربيه. طبعا اللاك اوف ريجوليشن او بريزنس اوف ريجوليشن واكسترا فيجن ناو عليك انت واكسترا سوبرفيجن مخلياتك فيري كيرفول. يعني مثلا لما بنبدا اي بروسيجر جديده تقعد تدير في ميتنج مع 20 واحد 7 AM ميتنج تايمز 5 باش يبدوا لك اول بروسيجر. قبل هدي يا عيال يا عم بوتي حازم يقول قبل في ليبيا ما عندكش من يخاف امشي جرب ما تنقصت رجله عادي.
يعني سامحني هو this is يعني we know for good for patient safety. احنا مضطرين نسمع بنختموا في خلال 5 دقائق. بنقول لكم حاجه بس الدكاتره اللي معانا اللي هو في الاتندنس يا ريت لو فيكم حد يعرف الصوره هذه اللي حطها دكتور عبد الغني يكتبها شنو المكان هذا. وحنختم بدكتور عبد الغني لكن بناخذ
في حد جاي
شارع الزاويه هذا
خليهم يكتبوها يا راجل. غير نقول لكم حاجه بس
يا حسره بالله كانوا ما يخلوش فينا نخش من الباب كنا امتياز.
يا عادل غير اسمع بقول لك حاجه. لكن شو نقول لك قصه الاتيتيود بتاع الكارديك سيرجن لما جابوا برانويلد ودخل الاوار وحط صبعك فصل الاورتيك فالف والقصه هذه شو الموضوع هذه برنامج زي
والله شوف
بتاع دكتور هاوس
والله توريك حتى كولابوريشن واضح ان فيها كولابوريشن يا جماعه باش يقنع باش ما نقولش قال جحا تعال حط جلاف وشوف.
خلينا ناخذ اسمه في دكتور عماد القويري عنده السؤال بعدين نبي نعطي كلمه دكتور مهيار دكتور منعم اخر كلمه وبننهي بدكتور عبد الغني نحط الصوره هذه يعني كده اتريبيوت للمستشفى اللي تدرب فيه في ايامات الاولى وتكلم هو دكتور الشفح بارك الله فيه.
لكن حاط قسم الجراحه يا راجل. قسم الجراحه
قسم الباطن ما مش حاجه يعني.
خلاص اسمع خلينا ناخذ الكومنت بتاع عماد وقلت لك وين كومنت على السريع من دكتور مهيار ودكتور عبد المنعم بعدين عبد الغني تقدر تختم. دكتور عماد خلي لك انميوت وتقدر تسال سؤالك او تحط الكومنت.
السلام عليكم جميعا. مشكور دكتور عبد الغني على المحاضرة. very aspirational. very aspirational. نحن كيانج أنا third year resident Texas Tech. very aspirational يعني ممكن في يوم من الأيام إن شاء الله واحد منا يكون زي الناس هذوما اللي بدهم الصفر يعني. سؤالي هو curiosity عرفت. وعاد الدكتور عادل جيب حتى هو طمعنا في المحاضرة بتاعه السلايدات اللي قال عليه. إن شاء الله مرة جاية إن شاء الله بإذن الله. من باب الفضول نحن في ليبيا شنو التاريخ عندنا؟ امتى first diagnostic angio؟ امتى first intervention؟ لو كان احد من الكبار مثلا يعرف وين المستشفى اللي كانت فيها first angio جست من باب الفضول يعني. احنا صغار والله ما نوعى عليهم. انا لقيت كل شيء مديور في ليبيا لكن كان في حد عنده معلومه ممكن يفيدني. شكرا جزيلا.
انا عندي لك اجابه سريعه باهي. انا يوم ليمات كنت نشتغل في تورونتو فكان في زي الميتنج ورك شوب فجاني البرفيوجنست هندي عرفني ليبي قال لي منين انت؟ قلت له من ليبيا. قال لي منين؟ قلت له من طرابلس. قال لي my name is Zahir. I'm a perfusionist. I was among the first team that opened the open heart surgery center in Tajura 1974 والدكتور فتحي الغماري. just to let people know that Libya Cardiac Surgery Center was opened in the 70s guys. يعني my age. I was born in 1974. فجست الهيستوري والدوكيومنتيشن Libyan Cardiac Center مش مسلاتة الأول ولا مركز طرابلس طبي ولا بنغازي القلب ولا الهواري ولا TMC لا في تجورة في ال70s. فقال لي I stayed there for a few years بعدين he went to England and then he moved to Toronto. فالهيستوري هذه من ناحية الكاردياك سيرجري. الانترفنشن I'm sure they come hand in hand يعني I think pretty much there's no cardiac surgery without intervention. فجست this is a brief يعني answer to your question.
والله سؤال ممتاز جدا يا عماد. وناس صراحه لو تواصلت مع دكاتره في ليبيا السينيور الموجودين في بنغازي وفي طرابلس للاسف ما قدرتش نحصل حد يكون معنا موجود. عبد المنعم مش عارف بحكم انك تو انت موجود في ليبيا هل عندك معلومه على بالنسبه للكاريكات ولا اي حد من الاكسبرت مان دكتور مهيار ولا عبد الغني؟
والله الحقيقة إن في التريبل يعني most of the hospital now they run the service. حقيقة مستشفى الخضراء تو بدو طبعا يديروا في أنجيوجرام وأنجيوبلاستي. في تاجورة أيضا حتى هي بت أكتف. في مصراتة أيضا أنا بديت معاهم، بديت يوم في الأسبوع غادي يوم الخميس نديروا حتى في التريننج للتيم غادي we start doing some I mean acute cases some elective cases. في شارع الزاوية أيضا في احتمال أن يبدو طبعا في شارع الزاوية. في الطب أيضا السيرفيس طبعا عارفين لها يعني في التطوير. quite few centers now they start doing the interventional cardiology.
في حتى دكتور محمد حميد كاتب ان بنغازي بالنسبه لاول هارت كات والعهده على الراوي ان هي كانت في 2001 بالنسبه لبنغازي. سؤال. شكرا بارك الله فيك عماد. دكتور مهيان لو عندك تعليق بعدين ناخذ اللاست كومنت من عبد الغني. وانا تفضل في مهيان لو عندك كومنت.
اهلا وسهلا. لا انا ما عنديش فكره على امتى بديت اول، لان انا ما كنتش كارديولوجيست. انا زي الجماعه انا كنت بي جي واي ان، فانا ماشي بكل 5 سنين حاجه. فكنت 5 سنين او بي جي واي ان، بعدين 5 سنين جنرال انترنال ميديسن، وبعدين درت كارديولوجي انترفنشنال كارديولوجي. الحمد لله اللي حتى هو يعني for a while يعني I multiplied the 5 years by multiple 5 ف I'm okay يعني satisfied. ما عنديش فكره
هو
بصراحه.
دكتور مهيان في الانترفنشن
واخر 5 سنين.
نعم
واخر 5
ما
سنين.
شاء الله. قديش لك سنه؟
لا من 2005 في الانترفنشن.
دكتور مهيار وما شاء الله اخر 5 سنين مؤلف وملحن ما شاء الله.
ايه حتى هذاك صح والله حق. هذه ال5 سنين الاخيره، 5 سنين الاخيره كلها في البرنامج هذا. الله غالب. بعد ما شاب خش الكتاب.
لا
الكتاب ما شاء الله. اللي يبارك ما شاء الله.
اوكي بارك الله فيك. شكرا.
لما قلت دكتور مهيار هو الموضوع شويه ممل بورينج، لكن انا يعني لما اخترت عبد الغني لاني نعرف عبد الغني جدا جدا، وقلت لك يعني تستمتع، واظن طريقه سرده كانت اكثر من رائعه، وزي ما قلت لكم ما زال في جعبته الكثير. فعبد الغني طبعا الصوره هذه نايس اتريبيوت منك للمستشفى اللي تعلمت فيه. طبعا انا من طبي اصلي، فانا وياك هيك المفروض حساسيات، لكن تفضل تقدر تختم. ونحب نشكر الاكسبيرت بانل والحضور انكم كنتوا معنا، وان شاء الله يا رب المحاضره الجايه في الانترفنشنال كارديولوجي حيعطاها استاذنا الفاضل الدكتور عبد الرزاق الجهاني على الاكيوت كورونري سندروم. ان شاء الله حنحطه اعلان الفتره الجايه. شكرا. تفضل يا عبد الغني وبعدك نختم.
الله يبارك فيك. شكرا جميعا على المشاركه، وشكرا على الكومنتس. مستشفى شارع الزاويه طبعا يعني ليه فضل كبير علينا ما في شك.